I'm happy to have you all on our webinar, Mastering ICD-10 Coding for Primary Care Physicians. Speaking on today's webinar, we have Cindy Kane, Senior Director of Physician Services, and Beth Ann Breedemeyer, Director of Compliance Consulting. Cindy has over 25 years of multi-specialty healthcare experience in medical operations, practice acquisitions, billing operations, accounts receivable management, AR and operational assessments, as well as coding and compliance. Beth Ann is responsible for McKesson's consulting services related to physician practice, coding, and compliance. She serves as McKesson's lead consultant on ICD-10 planning and implementation with expertise in ICD-9, coding and education, and transitioning to ICD-10. She has more than 27 years of experience in assisting physicians' office and billing staff with their coding and compliance needs. With that, I will introduce Cindy.
Okay, all right, thank you. Okay, thank you everyone. With our ICD-10 for our primary care, and when we look at primary care, we've also included with that the pediatrics and the OB/GYN. But hopefully everyone on the call is very familiar with ICD-10. But if we look at from our ICD-9, and the number of diagnosis codes that we had, then we look over to ICD-10, we can see, the multitude and the change that is in that number. This slide actually shows you the differences where we're going, from 3 to 5 digits over to 3 to 7. In the new ICD-10, your first digit will be an alpha, and then digits 2 through 7 will be numeric. In ICD-10, there'll be a presence of a dummy placeholder. Then if we look under ICD-10, when we go to our PCS of that, we're going to see, 87,000 procedure codes, the 7-digit codes, and then the format will be alpha, where previously we're accustomed to that being numeric. So this just shows an overview of what those differences will be. With our agenda, we will go over the index, some of the common terminology, some documentation guidelines, chronic problems. We have included some case examples, some wellness examples, and then we'll talk about using signs and symptoms, and then we will have a time for questions. But if we look at the index, this is the first place that you will go to when you're trying to find the specific information about a condition, a disease, a sign or symptom, or a clue that helps you find a particular code if you're reading an operative report. In ICD-10, you will use the same process as you currently use today. In this example, we would see here if we were looking under the B02.9, and first you're going to go to your word, whatever that condition would be in the index, if it references to see that. And then also you would see if we had no complications, under any part that you may be looking for, whatever that condition would be. So again, we're looking here at the herpes example, but we would see without complications. Actually, it would be the very first listing under that, which would be your B02.9. So again, the index is the same as what you used today when you're trying to find that condition, and then if it references you into another category. But some of the documentation guidelines with ICD-10 and the changes, it's going to be the greater clinical detail. It will update the conditions and diseases as we see today. You will actually, when we're talking about left and right, specific codes related to the site of the condition, the disease, or the injury. Under BMI and like pressure ulcers, it will be, the BMI should be referenced as a secondary diagnosis. Pressure ulcer will now include the stage along with the location when you're coding that. Under the complications of care, it will be clear documentation from the physician. And then as we have combination codes, there'll be some casual relationships between that area. And then many times I'm asked, signs and symptoms, and when to use the signs and symptoms. Those are the conditions, that become an integral part of the disease process, and they should be identified separately. Conditions that are not a part of the disease may be listed separately, as you add those into your final diagnoses from another condition. So you want to, continue as many today as you're looking at your signs and symptoms and being specific, but this is when, you would use your signs and symptoms when you're doing your coding. And some of the structural differences that are in the ICD-10, it will be under the sense organs. The eyes and ears have been separated from the nervous system, and they will actually have their own chapters in your ICD-10. In ICD-9, your V&E codes were incorporated into main classifications into the ICD-10, and then your injuries are grouped first by the specific site. So you would have, as an example, the head or the arm. Then by the type of the injury, is it a fracture, an open wound, and then versus, that type of injury that would have been in ICD-9. So a little bit of structural difference there with ICD-10. And when we talk about the placeholders, in ICD-10, they will utilize a placeholder, and it will be the character X. And the X is used as a placeholder at certain codes to allow for a future expansion of those codes. So an example of this is the poisoning adverse effect and underdosing codes. In the category of T36 through T50 in your ICD-10 book, for a placeholder exists, the X must be used in order for the code to be considered a valid code. So depending on what your top 25 or 50 diagnosis codes are that you're using today, you may want to do some cross-referencing and see if any of those codes are going to fall into a category where the placeholder would be, something that you would be using. This will actually, when we're looking at the structural difference, you can see here within the category, it's always going to be a capital letter. Then you're going to have always numeric. Then your etiology, that may be the cause, the site, or severity. That would be alpha or numeric. So you're going to have here again the next three codes. And then you've got your extension codes. And those would be alpha or numeric, additional characters that provide more detailed information about that condition. So if we're looking at bronchitis that was not specified as acute or chronic, this would be like J40 in your ICD-10. If we're looking at what is the difference when we're looking at, say, your specified codes, when you go with your orthopedic, you're going to have to know, is it an initial encounter? Is it for an open fracture, a closed fracture? So you can see here the example that we have when we're talking about the orthopedic diagnosis codes. And what additional details does the ICD-10 code provide? It's actually showing us the right clavicle, and then the extension was the initial encounter. So this will be very important if you are in the primary care. The patient presents, and it is suspected that there is a fracture, and you are the one reviewing the documentation for the coding, or the physician is actually selecting the appropriate codes. Again, their documentation will have to be very specific so that they can actually go through and know, is this the right clavicle, and is it an initial encounter? Again, what would that appropriate diagnosis code be? Some of the common terminology, this is not really changing in the terminology. So one of the things that we want to, remember, and as you're going through your ICD-10 training, if you're needing refresher courses on terminology, then, we have here, we've listed, this is under, endocrine. So we see that we talk about the diabetes, the hormones. We see here we have mental behavior disorders. We have the terminology here. What are some of the top terms that fall into those categories? So with your coders, with your staff, even sometimes with the physicians in their documentation, you may want to go over and review, again, with those that will be impacted by ICD-10, the common terminology terms and what those descriptions are. We have respiratory, so if we're looking here at the pneumonia, the sinus, the bronchitis, under musculoskeletal, the terms here. I think, again, with orthopedics, we're going to see a lot of changes within ICD-10. So, again, the terms and what are those descriptions. But when we talk about precision, accuracy, and detail of ICD-10 over the ICD-9, if you look here just at our 414.01 and our 411.1, the description, the coronary artery disease, the vessels, and stable angina within ICD-10 as it is today. If we look over to ICD-10, we see, we go now to 125.110. You can see the description here. We're talking about the heart disease, the coronary and stable angina. You can see how very more detailed the description is. So within the codes here, this is the change. So then from a documentation standpoint, again, this goes back to the physicians and that documentation being very specific. If we look at a detailed encounter information of 10 over the ICD-9, you can see here talking about the description, and we've got the myocardial infarction, and we can actually see that, we've got elevation of the stem, we've got ST elevation, because it's a subsequent. We've got our codes here. So, this is like if we've had the heart attack within the 8 weeks. We have the code that we would be using today. But if we look, now the codes and what they will change to, you can see that it changes into the ICD-10, that it is actually the MI within 4 weeks. So again, very suggested to be looking at, your specialty, your top codes, how are the codes changing, and what documentation may be changing with that. Again, if we're looking here at some of the others that go under with our hearing loss, whether it be the right ear, the left ear, bilateral ears, the specified ear, because you have to have your audiology testing. Again, we had in the past where it stayed the same code, 389.8. You can see now with 10, we actually do have the specific codes based on, the lateral of the right ear, the left ear, bilateral ears. So this is just an example of showing, precision, accuracy, and detail that falls into 3 different types of scenarios here on this one slide. On a comparison, if we're looking at currently tobacco abuse, there's 1 code. This will go to 5 codes. When we're looking at diabetes, currently there's 10 codes. We're going to 318 codes. And then, the large one into orthopedic with fractures, there were 33 codes, and you can see that it will be going to 1,818 codes. So a huge impact, again, just in these 3 areas of, the specifics and what you will need to make sure that, you are utilizing the correct codes. The next few slides that we will go over will actually show you some examples. So these would be within a primary care. You may have patients that would present with this type of condition. We will try to go over as many of these as we can and still get to a lot more within the presentation. But if we had a 46-year-old female on this particular scenario, presents to the physician's office for evaluation, had fainting this morning at home, and after the study with the physician, he determines that there was no reason that he could find for her fainting. So he's coming up here with his actual, here will be my diagnosis code. So you would look in the index, which shows you the process, and then you're going to find, what the fainting would be, and then you're going to see that there would be in ICD-10 a diagnosis code that would start with R, and then it would be 55. And so this would be, for this particular scenario, this would be that correct code under just a general fainting. If we go to headache, we see where there's, again, a patient presents to the office for evaluation of headaches. She states that the headaches are frequent, but she can't pinpoint specific events that may bring them on. So the physician examines the patient and determines that these are actually just a chronic tension type headache. Okay, so again, if the process you would look in the index, your headache, then it would process down would be the top would be tension, and then you would see that there could be the chronic type of headache. So this would put you into the alpha G, and then it would be 44.221 because this is actually a chronic tension type headache. So if you have started the process in your office of looking at some of the mappings or cross-reference of your top codes into what they would be within ICD-10, you'll notice as we go through, the different scenarios that the codes you would have used in the past, it's going to be a learning curve and a learning process for everyone involved to know, where are the alpha and then what are my numeric for that, for the codes. Depression, we won't forget about that catch-all. In the past, we would fall under the series of 311 for depression. But at a minimum now, you will need to identify if it's a single episode or if it's recurrent. So that puts you in where you would be looking at, again, is it single or is it recurrent? Then there will be choices. So let's say, this is a single episode. The next piece of that would be, is the depression a mild, moderate, or severe? The digits, that you're going to have a 0, a 1, or a 2. Then, are there psychotic issues that could be occurring? That would take the code to a different level. Or is the depression in remission? So many times, myself as a coder, and if I'm looking at documentation, sometimes that catch-all, the physician will have documented patient presented today for depression. They may say weight loss. They may say headache. We may see some other types of documentation. But again, I would many, many times just see the 311. So now that physician or that clinical provider has to be very specific in how they would document just a depression, because now you do have to know, the different items that go with that code and what the payers at that point in time, and how the edits will be set up as to what they would be looking for. If you're having malignant neoplasm, this again is an example, but as you go to your index, then you're going to have to look at the neoplasm table, and then you would look at the stomach, you would look at the body. When I reference the neoplasm table, that is something that if your particular practice, you're having a lot of neoplasms, we can make that available for you, the table, because that is something that is available, through the CMS website. As we can say, I was going to try to, move, pretty quickly through some of those that we have. So, as we go to some of the different ones, you're going to see that we've tried to put in some examples that show, even if you're within the pediatric scenario, and there's some different types of case examples here that would be beneficial for you. Glaucoma, this is one where we have the patient that presented. This could be to the ophthalmology clinic. The primary care provider referred, was having some visual problems, but you may see, these patients in your office because as the primary care provider, and if your patient has diabetes, the primary care providers usually do follow up, to make sure the patients are having their eyes examined. But, if this was to where they had glaucoma, again, the index, glaucoma, but then we have to look at the open angle. So the diagnosis code, again, the H4O.100 is an unspecified open angle glaucoma with the stage unspecified, because if they're saying it's just a general open angle glaucoma, then you can see that that does fall. Terminology here, it may say the stage unspecified, but again, you look at the index, you go to what the problem is, and then again here, the key is that that physician has documented open angle, because that is now within that terminology, and that would be a requirement. If we're having ear problems and we're having skin problems, This again shows, where we had with a patient with the allergies, it was chemical related. So some of the key words as you go through, and hopefully some of the case scenarios that we've included here, you go through and see that these are maybe some of the common type things that present. If you in the past have looked at some of the physician documentation, hopefully you'll be able to see that, some of the wording, some of that documentation, again, with this one, just because they presented to the office, they're feeling like it was a chemical reaction. Again, sometimes we could see physicians may code rash, and that would be it. But with this, again, their ICD-10 allows us, as we were saying in the beginning, to be very, very specific, so that way we know exactly what we're dealing with and what needs to be documented, so that it will allow us to then drill down through the index and have that specific code. Swimmer's ear. This is very straightforward on this example, but the 25-year-old presents having pain. She's part of a swim team. The physician does the examination. Just easy to determine it's swimmer's ear. So again, our code here is for the right ear. So that falls again, in your alpha and then the appropriate numeric. With hypertension, one of the things with hypertension is that being specific as to what we are looking at and how the physicians are documenting. On this scenario, this was a patient that actually just went to the local supermarket, had the BP check. It showed that it was high. They now call, the physician decides that, due to the blood pressure issues, to increase medications, they've asked that, they buy a blood pressure cuff so that they can themselves monitor, get some accurate readings. So if we look at under the index and just hypertension, we actually can see that, in other words, we have here essential primary hypertension, but we need to note that even though he has uncontrolled BP, it is still coded the same way. So again, looking at hypertension, you'll want to look at all of the different scenarios and the diagnosis codes within hypertension, because there are some changes there. And again, going back to being specific, I know that we say that, many times over and over, but that is the things that, in order to choose the specific ICD-9 code, it is a reflection that goes back into the documentation. With diabetes, we see that the scenario is that a 25-year-old female is seen at the diabetic clinic for evaluation of her type 1 diabetes. The patient is doing well, watching her diet, exercising 4 days a week. She carries her snacks. She's very aware of her blood sugar level when it's low. And she'll return to the clinic in 6 months or sooner if she has any questions or concerns. Basically, this is your typical diabetes type 1. So if you look in the index, then we see diabetes type 1. We will see here that the code of E10.9 falls into that category of the diabetes without complications. Then if we have diabetes with CKD, to where we have the chronic kidney disease, this is where, this has been determined, the documentation states that. One of the things that, we may call those manifestation codes today, but if we look in the index, we look at diabetes, and then we look at chronic kidney disease. Our E10.22 is our type 1 diabetes. That does give us the description of with the chronic kidney disease, but you also will have to know what stage of your chronic kidney disease, because it can be from stage 1 to stage 5. So again, from the documentation, from lab test results, and from the physician, we would see that then we would also have to code our N18.3, which does specify the chronic kidney disease, CKD, and it would be stage 3, which is moderate. So you would have to have those codes. If we have end-stage renal disease, you may have a patient that has diabetes, but instead of chronic kidney disease, they may have the end-stage renal disease. So again, this is just if it is strictly been the end-stage renal disease would be the documentation and the appropriate diagnosis code, but you could also have the diabetes and have your N18.6 also if both were being addressed at the visit. Then we have an example here of a Medicare female patient that has osteoporosis, and she also has had a pathological fracture. So in our ICD-9 world as of today, we would have our codes of 733.01 and 733.11. But in ICD-10, here we have a lot of choices or selections. So we have our alpha code, then we have our numeric, but we have an A, but would it be a D, a G, a K, a P, or an S? So you can see it's almost a multiple choice, because which side, was it left or right, that reflects one of the codes. So then we go, what type of encounter? You know, if we go back from the beginning, was it an initial? Was this the type of encounter? Was it something that was sequel? Was it subsequent? What type of healing is occurring with the fracture? Was it routine? Was it delayed? So you can see in this one scenario to where the drill down when you go into the index versus what has been documented by the physician. Now again, you know, for you that are coders on the call or for physicians that may be on our call today, we can only code what is accurately documented. So again, you know, we have to remember what our payers and how they're setting up their edits and what the codes will be that they're looking for. So one of the things that we still don't know is that, let's say the documentation did not support and you simply have omitted and you're sending in, you know, say partial of the code, normally that is going to be rejected. So now it's going to come back. There's going to have to be additional follow-up. So you can look at the time involved. So, you know, since everyone is into the ICD-10 arena, it's giving you an opportunity, depending on, you know, your codes, the type of patients you see in your practice, to say, what are we doing today? So, you know, I've encouraged a lot of offices to say, if you took 5 examples today from your office and you sit down and you look at the documentation, is the documentation specific enough that it would support, in this scenario, if this was a scenario you would have in your office, the ICD-10 codes. So there are some things that you can start to work on today in looking at, you know, what is occurring and what is happening, and do you need to improve in certain areas, and what would those areas be? We still have our preventative diagnosis codes. So again, when you're having your children come in, you know, this 2-year-old, this is a 24-month checkup, then, you know, she's doing well, no complaints. Again, you're looking at the index, the type of examination being preventative. The child was over 28 days old. There was no abnormal findings. So it gives you the appropriate code. This is another preventative diagnosis example here. So we gave you a couple of preventative. This is one to where we would be having, this would be more within your pre-op. So this would be your visit, because they're going to be having a procedure. And so you would actually be able to go through, and their patient is seeing you. They're having upcoming lung surgery. Again, as you do your pre-op coding today, then there will be the specific codes that you will still have under that preventative window within the primary care office setting. But some of the documentation problems that may come into play is the being specific diagnosis code and identification of conditions that will contribute to the complexity of a disease. The identification of the severity. Is there a comorbidity? Then what are the stages of disease? You know, we looked at the kidney disease. If there's dementia, if there's asthma, what are the stages? And diabetes, you're going to have, you know, what is the severity of diabetes? So you want to make sure that, with your patients, you review the complete histories of the present illness, but also within the follow-up visits. Also, you want to look at, some of the documentation problems. It's what we call cloning, and you copy forward and copy paste. One of the things that you want to make sure, especially with your EHR, is that if you are utilizing to where there's not that cloning and you're pulling information over because something could have changed, within that. So these, that as we see as of today are your top 6 or 7 issues that you may have some documentation problems in. So you want to make sure, again, maybe this could be kind of a checklist to say, are we having issues in any of these categories? And if so, what can we address and what can we correct, or how, the additional training that we may need in order to correct these issues. Preparing, the next couple of slides will show you, this is actually from a family practice super bill that was taken, ICD-9 codes that would be top codes in a super bill diagnosis section into ICD-10. So if you look at this, and you can just see the different areas here, you can see if we're looking just here under the infection and our parasite diseases, right now you would have 6. That will go to 25. If we look down here under circulatory systems, under cardiac, currently today there's 4. That will go to 34. So this shows you the volume. So if you're still utilizing a paper super bill, you can see how many pages that super bill may become because of the codes that, will be listed. Here is, as we also the impact to the providers, if we're looking at descriptions, this actually will show you, again, a sample here that is going just from our infection, our parasitic disease from 9 to 10 on a family practice super bill. You can see under 9 the number of codes, the code description. You can now see under ICD-10 translation, there's 25 codes. And you can see here what those code descriptions are. So again, one category, but look at the volume and then the descriptions. So it is forcing, to be specific within that, so that then you can go through and that you can then assign what would be the specific appropriate code based on the documentation. This is actually, again, it's a continuation of your diagnosis section. But, one of the things that really stands out to me is when we're looking here at musculoskeletal and connective tissue, if we look at general and we see 6 and we go to 215. If we're looking under signs and symptoms currently of 32, it goes to 191. Then if we go under injuries, adverse effects, and you look at trauma, we currently have 5, it goes to 243. So within this page, it goes from 1 page to 8 pages. You were at 164 codes. You're now over 1,000 codes. So again, a process, what are your top codes? What would be the appropriate ICD-10 codes for those? So there's many things that, you as offices, if you've not started the process, that you can start the process of, what is the impact, and then looking at, what you can do to say, let's look at what we need to pull in from our current system, and how can we, continue to move forward and be ready for the ICD-10. But some educational tips for coders is, again, evaluate your current encounter form for common diagnoses and what are the most frequently ones in your practice. Find resources that are very specific to your specialty. Check with your specialty societies for specific resources that's related to ICD-10 that can help you. You want to learn about the crosswalks that are between the codes. And again, some may not be a perfect match, but start to look at those as to what will benefit you in your office. Learn from the crossroads, learn about them, what goes, between the two. And then, anatomy plays a very big piece of ICD-10. for specific areas or specialties. So you may want to, start to say, do we need to have refresher courses? Do we need to look at different, some of the hospitals that you're associated with, maybe having classes? If you're a coder, you belong to AAPC. So, what are the situations in your office? What is the level? Who's impacted by ICD-10, and what processes can you start, within your specialty that will make the transition, hopefully streamlined for you. For providers, education for you that are responsible in your organizations, you want to continue to work closely with the providers regarding the change and the impact. If you have not already started, please, look at that as a possibility, but continue to monitor the documentation in the medical record for medical necessity. And, what is it supporting? If you're currently on an EHR, evaluate the use of your EHR for the documentation-specific changes that will need, to go in place from ICD-9 to ICD-10. If you were in the process of going to EHR, there is a transition period that in a learning curve for your entire office once you're on EHR. But, if your EHR, once you've been on that for, say, 3 months or 6 months, then you can go back and evaluate the process and how that will impact from ICD-9 to ICD-10. The physicians, providers need to work very closely with coders to help to make sure, there is a smooth transition into those ICD-10 documentation requirements. If you do not employ coders, you work with outside entities, in that respect, again, work to see what that education would be so that it can be an easy and a smooth transition for you. The resources that you have, is to, look for additional educational trainings throughout the year. Remember that everyone is involved with the transition process, and working together will result in the best possible outcome, not only for the physicians, but for the practice. And ask questions. Please do not be afraid to ask questions. The question you have and the person you're asking the question to, they may not know the specific answer, but they will hopefully be able to steer you in the direction to the resource, or they can find out, what that answer would be for that specific question. Then we come to our questions. And I believe Nicole had instructed on how to submit your questions. And I will turn it back over to Nicole and then to Beth Ann if you have anything you would like to add.
Thank you, Cindy. Yeah, before we get started with our questions, I wanted to introduce the next webinars in our ICD-10 series. Starting on May 14th, you can see below some of the specialty-specific webinars we'll be having. And you can register for those webinars today at med3000.com/webinars. And we'll go ahead and move into the questions portion of the presentation. We've gotten several questions throughout the presentation, but would encourage you to continue submitting them. One of the big questions was, will the presentations be available on demand after the webinar? And the answer is yes. We will make these available in the next few days and send them out to the attendees so you'll have copies of those. And then the first question after that, Cindy, to clarify, there are 155,000 diagnosis and procedure codes under ICD-10 versus 24,000 under ICD-9 based on your first slide. Is that correct?
That is correct.
Okay, thank you. The next question we have is, going back to an earlier slide, what is the correct ICD-10 code for a single episode of mild depression versus ICD-9? Thank you.
Okay, and if I can, Beth Ann, can I defer that over to you since I currently do not have an ICD-10 book in front of me?
Cindy, maybe that's one we could follow up on after.
Yes, let me follow up on it. If you can email me that one and who that question, then I will definitely follow up on that one.
Okay, great. And then someone also just asked if they could get a copy of the slides in addition to the video portion, and we will be having those as well in the next couple days here. We're just getting a couple more questions coming in as I speak. Cindy, is there anything you wanted to add based on?
Well, I think, one of the things that I want to, for everyone to realize is that, when we do talk about ICD-10, it is very large in that topic, and our presentations is at a high level to hopefully be able to provide some resources, case scenarios, things that would impact each of the specialties, even with our upcoming webinars. And I think that that's one of the the levels is still stressing to the individual offices that the training, the resources they need to look at, what the needs are, that they're conducting that evaluation. We're not the webinars are not to say exactly here's how you're going to code every example, because you do have to look at the documentation, but to give hopefully some beneficial and some insight into the direction that ICD-10 is taking, each specialty that we have. And then through the questions, as you had stated, Nicole, and the services, that are offered through McKesson, if offices need additional information, then we can address those, with those individual offices.
Perfect. Thanks again, Cindy. How quickly would the ICD-10 codes be utilized in the industry?
What is being said is the codes do go into effect October 1, 2004. There has not been an extension. From our perspective, as we have contacted national payers throughout the United States, they currently are saying they will be ready and that they will also be going into effect exactly when Medicare does. So at this point, I would encourage everyone not to anticipate an extension, to continue to work, to be ready. Just the way you had 50-10, just the way you have meaningful use that needs to be, implemented, is to still go to that date, because it is a very big task, and you don't want to be, waiting 90 days ahead of time and be trying to go through all the processes you need to go through. So, everyone is currently stating that that effective date is not going to change.
Okay, thanks again, Cindy. And the next question, you identified a patient as a Medicare female with osteoporosis. Is Medicare going to have an exclusive diagnosis code?
Medicare will follow the ICD-10 codes, because ICD-10 is very specific. I believe probably whomever submitted that question, we now have what we call G codes, but Medicare will be using the ICD-10 codes just like all the other payers, and it will go by the specific code based on the documentation or the patient's symptoms and what their issues are for that particular visit.
Great, thank you. Are there any mappings for DSM-5 and ICD-10?
I'm going to say yes, but if you will send me that specific question and let me follow up, and then I can provide you, Nicole, with the follow-up.
Perfect. Much of the work for training will depend on how ICD-10 is implemented in the EHR. When will details about the implementation be available?
Okay, okay, I guess I will.
I'm not sure that's real clear.
Clarify that question. Right. Implementation into an EHR is based on the EHR vendor that you're currently using. So for the attendee that asked that question, I would say you want to follow up with your vendor as to who that vendor is, and they should be able to supply you with that information, because many vendors are giving their clients a date that there will be ICD-10 in there so that the physicians can start that training process so that they can start to see what that mapping will be. So again, it's going to be very specific to the EHR vendor.
Perfect. Thank you, Cindy. So I'm just reading some of these last ones. And we've got a couple questions come in on specific to which specialties we'll be doing our next webinars on, and you can find those on your screen. There may be more after that, but those are the specialties we have identified at this point. Do you anticipate further changes to the ICD-10 codes, or would you recommend purchasing current resources for ICD-10 out there as they are now?
I would suggest to go ahead and purchase the current ICD-10 book, because that will allow you to start to look at your top diagnoses in your offices and then say, here are the ICD-10. And again, you know, as we all know, there can be those last-minute updates. So again, there may be some updates, but at least you have accomplished 99% of your work in mapping and looking at how diagnoses will change for your individual offices based on your physicians, you know, say top 25 to 50 current ICD-9 codes. We are currently using the ICD-10 book for training that we're doing, knowing that we will have to go back and double check on a couple of issues. But I would encourage everyone to go ahead and, you know, at least order one book if or if you do it electronically, you know, whatever you do in your office when you purchase your coding materials.
Great. Thank you, Cindy. And then we had someone ask if you can remind us of the start date again for ICD-10.
Okay, the start date is October 1st, 2014.
Perfect.
So we have a little over a year away. So that's why, you know, as we had talked about, you know, with your physicians or your coders, if you need to do some training on anatomy, you know, this gives you hopefully time to do an evaluation of your facility or your office, see what your needs are, and hopefully have your plan in place, you know, and be ready.
Excellent. Well, that will conclude our webinar today, and we hope you all can join us on our next webinars starting on May 14th. And again, if you have any additional questions, please go ahead and email those to marketing@med3000.com. Thanks again, Cindy.
Thank you.